Great. Anim, bonjour. Hello, everyone. Welcome to today's virtual peer sharing and learning session, Models of Sharing Resources in Primary Care. We're going to give everyone a couple minutes to sign in and maybe grab their lunch. As we do, please introduce yourself in the chat box, your name, your OHT, Primary Care Network organization. And for those of you I haven't had the opportunity to meet yet, my name is Leslie, and I'm a coach and focal point with RISE, supporting population health management and primary care. So thanks, Mike, for introducing yourself. We do this as well so that in between sessions, you can reach out to your peers because we always have some great discussions. I've also brought up on slide here another space that you can use between sessions to stay in contact with your peers, post questions to us, stay up to date on different resources, and then of course also see recordings of past sessions. So today we are recording and we recognize it's March, and so it's a very busy time for many people, so they might not be able to join today. And also we know it's March break. So we will record today and place it in this space as well. And I think Kaylin's going to put the link for you in the chat box in a moment. And if not, we will share those slides after today. So keeping in mind, we also want to keep this session to 1 hour today because we want to be cognizant of everyone's time. So to ensure we leave lots of time for discussion, I am going to start our session, and I'm going to pass it over to my colleague at the Northern Ontario School of Medicine, Jin Fan, to provide the land acknowledgement today. Jin Fan.
Can everyone hear me? Yes. Hi everyone. Great pleasure to deliver the land acknowledgement. I acknowledge that my place in Toronto is located on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Huron-Wendat people. And Toronto is covered by Treaty 13. I also acknowledge that my place of work, Northam University, respectfully recognize that our Pan-Northern campus is on the homelands of First Nations and Métis people. The university buildings on the Greater Sudbury and Thunder Bay areas are located on the territory of the Anishinaabe nations, specifically Anti-Convention Anishinaabe, Wanapete First Nation, and Fort William First Nation. As someone of Asian ancestry and a young researcher working in this space, I'm grateful to live and learn on these lands. I recognize that I am a guest here and carry a responsibility to approach my work with respect, humility, and ongoing commitment to truth and reconciliation. This means being attentive to whose voice are centered, whose knowledge is recognized, and how my work can contribute to or challenge existing systems. I'm committed to listening, learning, and supporting Indigenous health, sovereignty, and self-determined priorities in ways that are meaningful, accountable, and guided by Indigenous communities. Thank you.
Well, good morning, everyone. I just want to remind everyone of the objectives for today. We're going to be looking at approaches and strategies for how to share resources across different types of models of primary care, especially with a focus on how do we share resources with solo practitioners, get a better understanding of those resources, and continue to do the learning and exchanging that we do through discussion after the presentation by our guests. Next slide. If you haven't seen it before, you'll probably see it again. We do this at the beginning of every presentation. This is really our North Star. We're trying to take the current siloed, confused, chaotic system that patients tend to see and combine that into an equitable care organization that's fully integrated with primary care and patients at the center of that system. Next slide. This is a slide just to give you an idea of the drivers of how we get to that fully functioning, high-performing primary care team that's the center of the integrated care. We have the 8 drivers there of interprofessional team-based care, timely access to care, patient partnerships and community engagement, leadership and accountability and governance, relational continuity, population health management, digital health, and performance measurement. All of these we'll be talking more about in the next year and going in depth into these drivers that produce high-performing primary care teams. Next slide. What we'd like to do is do a quick poll around those particular topics. I know you don't know everything about them, but based on what you do know, please select the top 3 of those topics that you would like to hear about in the next year. So you'll see what primary care topics would you like to learn more about and select your top 3. And we'll give you a few seconds to click on your top 3.
Lots
How
of
do I know
options.
when they're How do I know
Yeah,
when they're done, Leslie?
I can let you know. Lots of options for everyone to choose from. So we're just at 40% of people right now. So maybe give it a couple more seconds.
Okay.
Um, yeah, still a couple answers coming through. Okay, I think we're winding down now. So if you've not locked in your response, just add it in quickly now, and you can always email us after the session as well.
Okay. Oh, terrific. So we see there's a split between interprofessional team-based care, timely access to care, and population health management, which is, and also digital and data analytics actually across the board for the most part. So thank you very much for that, and we'll take that into account as we develop our curriculum for next year. Now I'm going to turn this over to Dr. Rob Reed, who is one of our co-leads at RISE, and he will talk a bit more about creating effective primary care teams.
Yeah, nice to see everybody. And this is just a lead on from our last sessions that we've talked a lot about team-based care. As you know, interprofessional team-based care is the central driver to high-performing primary care. And we've talked a lot about how to create teamness and the importance of really how you lead and how you manage to create teams that are highly functional. Just as a recap, recall that primary care these days and contemporary primary care is a team sport. It really it requires a variety of different members in different types of roles to each work together in a highly interdependent way. Members rely on these teams, rely on each other for many clinical and non-clinical tasks. And the more that they communicate, the more they coordinate, the research suggests that the outcomes are better. The outcomes for patients, the outcomes for cost, the outcomes for health status, and then the outcomes as well for teams. Teams really, really like working together when they're highly functional. And recall that most effective teams do this by really focusing on building relationships and building communication channels. And what do we mean by that? Relationships are built based on shared goals. Everybody has to have the same goal in a team. Shared knowledge about what everybody's role is and who does what, when, where, and then really respecting those variety of roles and tasks that everybody on the teams are doing. And to do that really well, the team's members really have to communicate well. And what do we mean by that? It means communication has to be timely, has to be frequent, has to be accurate, and has to focus on solving problems for people. And when you do all of those things, which we call relational coordination, we know that outcomes are much better in teams. Okay, so that's where we were. That's what we've been talking about for the last few sessions. And we've been talking about now how do managers and how do leaders create these types of teams that are built on strong relationships and strong communication channels. And so you've heard a variety of leaders across Ontario that have been very successful in doing this, and they've told you about their strategies. Today, we're moving a little bit beyond that, and we're going to now talk about team composition. Let's move on to the next slide, Leslie. As we know, these types of teams can be configured with different memberships. And then this is just an example a hypothetical example of a primary care team that's composed of several physicians, nurse practitioner, other clinical people, including a social work, pharmacist, and an RN, and then people that provide non-clinical services that interdigitate with them, like medical office assistants and IT personnel. So this is just a hypothetical example of what a primary care team might look like. But there are many other types of examples out there, and maybe in the next session, in the next year, we can spend a little time talking about optimal primary care team compositions. But this is just a hypothetical one out there. So then, how do you put these people together? Let's go to the next slide. This is one way that that it's clearly done is we're all in one organization. We're all led by the same people, and we all work within the same goals. And an example of this might be a community health center. Okay, but many places across the world, this is the type of framework the primary care team operate in within a single organization. In Ontario, outside of community health centers, this isn't very common. And so next slide, Leslie. This is more often what you see is that there may be two affiliated organizations where there's a physician organization or a clinical organization that interdigitates with another organization that has other personnel within it, and their formal affiliation of groups, a memorandum that occur between these organizations. But this isn't that common either across Ontario. And so what is more common is the next slide, is really where, go to the next slide, Leslie. This is more common, is where there's multiple organizations now that really try to share personnel across organizational frameworks. And so there may be solo or small practice physicians interdigitating with other organizations that supply people with nurses, pharmacists, IT personnel, and so forth. And there's a real heterogeneity mix across these organizations as to what this might look like. And we're going to hear a really terrific example today about how we may support these types of practitioners that are outside of practices in big practices, and how we might support them in their community with other types of personnel, okay, to create those teams that we've talked about. Next slide, Leslie. And then, but remember that we still are trying to build the goal of these teams, that we really want these community physicians, these small practice physicians, and these organizations to be tightly interwoven so that the team, that we build relationships and we build communication channels for those team members to function and operate as one. So how does this actually happen then? Because it's more complex across organizations than it is within a single organization to make this come to fruition. But there's some certain recipes that are important, and you're going to hear a few things today that have really a good example of how these things are brought to life. First, about the importance of setting ground rules across organizations and across people. This is about setting common vision, common goals, and a governance structure to operate the shared work that we're doing together. And that comes to life often through service agreements or affiliation agreements, the creation of standards that we all operate by, and around accountabilities. We will do this for you if you do this for us type of idea, okay? And even more so, it's often really important to define roles and responsibilities for team members, for those team members that are particularly stretched across different practices, so that they have similar work in one practice when they move to another practice and so forth. That facilitates work. And then there's some certain structures that really facilitate this teamness. And this is where research has also shows is the importance of shared protocols, shared directives like medical directives, and shared standard work templates around how we're actually going to accomplish the work. Here are examples of that today. The importance of shared information systems. It's hard to communicate well without shared information systems. And so particularly optimal is if you can share an EMR. The importance of shared meetings and shared huddles, the importance of performance metrics, that we're all on the same page around what we're intending to go. And then we know that in teams there are conflicts that occur. And so there has to be some conflict resolution mechanisms that are built in. And then finally, spending time creating these teams. Teams don't just naturally happen. People have to be brought together, begin to understand who they trust each other, and so forth. So I'm going to leave it right there. This is just a little bit of an orientation around some of the things that make it complex as we build teams that stretch across organizations into communities. And this is the journey that we're on in Ontario. So I'm going to now hand it back to Mike, and we're going to introduce our guests.
Great. Thanks so much, Rob. As Rob alluded to, we have two presenters today to talk about a very innovative way of sharing resources, especially to support solo practice or small group practices. And that is Dr. Sandeep Banwat and Andrew Bilton. And I'll let them introduce themselves. Take it away, you two.
That was about the extent of my introduction, so thank you very much. So thanks, Mike and Rob. My name is Andrew Bilton. I'm the Executive Director for CarePoint Health, and I'm here with my colleague, Dr. Sandeep Banwat, who's a family physician, and he's also the Clinical Director at CarePoint as well. And both of us have quite a bit of history with CarePoint Health, going back to about 2017, where CarePoint started with the Mississauga Halton Lynn. And we both had roles in that organization. So, and then transitioned in 2019 to when CarePoint actually opened. So quite the history of building this from really an idea to a piece of paper to really to where we are today in terms of the maturity journey that we're on. Just maybe go to the next slide. So really wanted to just, there's sort of a lot about CarePoint and lots of things that we could talk about CarePoint, but thought it would be best to maybe focus our conversation today on really what is CarePoint in the local context, and why was CarePoint, our model, really a necessary way that we had to, in Mississauga, think differently about how to look at teams and how to extend team-based care access and resources to our primary care community. And look at also how primary care can take those resources, in some cases beyond the roster, for lack of a better word, and really also try to support the community, looking at the community needs and the population health needs, such that it is a bit of a fluid way we can share our teams across the community. And so really looking at, our shared experience with really building these teams, reaching out to primary care providers, talking about this, getting them on board. What are some of the things that we've done around setting expectations with those primary care providers in the community, roles and expectations, how we, use the word, using the word teamness, how do we actually function on a day-to-day level in terms of communication, expectation setting, conflict, all those things that Rob highlighted. Some of our lessons learned, and really wanting to recognize that we are on a maturity journey. There are places that we are still having challenges with. It's not a perfect solution, but that we, have started at a place, and we're continuing to move this forward to really think differently about how do we continue to improve the way that we're doing it. Can you move to the next slide, please? So I'd like to start with the sort of the Mississauga landscape. And CarePoint is based in Mississauga. We're part of the Mississauga Ontario Health Team. Mississauga, very large population, close to 1 million people, attributed population, highly urbanized, very limited access historically to team-based care. And prior to sort of CarePoint, there was about 8% team-based care. 2 small family health teams and a satellite site of a CHC, with predominantly solo physician models in the community, with over 700 primary care providers across all different funding models, numerous walk-in clinics, so different types of access for patients, but really a lack of support for solo practitioners and their patients to be able to access those comprehensive services that patients who require that extra level of support would benefit in a team-based care environment. Next slide, please. So CarePoint was established, and we are an Ontario Health funded organization. And we really have, I'd say, two sort of streams of what we do in terms of our core business. The first is we're an integrated primary care center. Officially, we're a CHC on paper, but we don't truly operate as a CHC. It was really like a contractual model that was available to us at the time. So we are funded through an MSAW agreement as a CHC. And we're also a mental health organization funded through Ontario Health for the Ontario Structured Psychotherapy Program. And we lead that program for Mississauga, Halton, and Brampton. I'm not going to speak about OSP today, but feel free to email me after if you have any questions about OSP. And really wanting to look at how CarePoint has deployed a practical and a scalable approach to reaching out to community providers and connecting them to team-based care, which was really the problem in Mississauga. And you know, how do you sort of take an environment where there are many physicians, they work either by themselves or in a small group. They may have an office with 2 rooms, different EMRs, no access to these services. And how do you start to connect people in to a team where we can start to build a relationship and start to build local networks in a bit more of a medical neighborhood model, which really makes sense in an environment like Mississauga, where we don't have, you know, one team for an entire region and 90% connectivity to team-based care. But looking at how do we start to build these local geographical networks to build those relationships and make sure that we can support those patients in primary care, and also build the infrastructure to be able to respond to community needs and build programs that are more targeted towards the population needs as well. So we are now a network of over 130 primary care physicians that are affiliated with CarePoint across Mississauga, and we serve 2 main locations, but we're expanding that to have better geographical access. And we provide access to services through that affiliation model with those solo practitioners in the community. Next slide, please. Not going to go through these. I think this just shows we do have sort of the wide complement of services and programs that many, you know, primary care teams have. Types of team members we have are, you know, dietitians, social workers, psychotherapists, psychologists, drop-down psychiatry, nursing, NPs, health educated pharmacists. So really that full complement of disciplines that work within our team and work with the family physician in the community around the patient's needs. Next slide, please. I'll turn it over to Sandeep.
Hi, thanks, Andrew. And thank you for having us and allowing us to share today. So my name is Sandeep. I'm the clinical director here at CarePoint. This is a busy slide, but we're going to go through this really quickly. The first 2 sections here, as Andrew mentioned, you know, our affiliation is with primary care physicians in the community. And as we said, that, you know, the original goal was how to extend team-based care services to community family physicians, assuming we're not going to co-locate in the same physical space. And that was the intent of what we're doing in a highly dense urbanized area. And as Andrew said, there's, you know, 700 family physicians in our region. What's the best way to try to achieve that? And it's done through an affiliation process, which I will expand on in a couple of slides. And it's, again, regardless of physician funding model, so fee for service, FOs, FIGs. We don't partner with the 2 family health teams in our region, and we open it, and I'll get into a little more specifics about the affiliation of what we ask during that process. The second kind of component is kind of the local networking, and that's supported by our practice facilitators and engagement specialists who are actively in the field and seeing physicians in person and connecting with physicians and creating that relationship. And number 2, I will touch on that in a couple of slides a little later as well, just to expand on that premise. But that's more for education and knowledge translation and planning and creating a community of practice specifically. In the third quadrant, we have a lot of community-focused programs, and 3 and 4, we're not going to really is not the focus of today's presentation, but we just wanted to highlight, as was mentioned, some of our community-focused and population-focused areas as well. We provide episodic care for newcomers, refugees, and asylum seekers in our region, and we're connected to the settlement agencies over the years as we've created partnerships and identified needs and gaps. We are the designate for the Ontario Diagnostic Centres in our region for breast screening, Ontario breast screening and lung screening programs for unattached positive breast or lung cancer screening positive patients. We do a lot of health promotion to local community groups as needed. Eden Food Bank, for example, locally, we're connected with and provide on-site supports if as needed as well. We provide health promotion to seniors groups and on an ad hoc basis in terms of health promotion activities. We do vaccine clinics in the community through our nursing team as well. So a lot of community-focused programs. We're in partnership now with the Victim Services Appeal and some of their clients who are coming through as a new partnership and providing immediate need healthcare that they found was a gap in the healthcare system. So really providing that community and social services aspect. And on the same time in 4, we provide, supports from an OATH regional level internally, we do a lot of health equity and social determinants health work and ask those of our patients who come through our doors. But more regionally, we're kind of the lead for the integrated care pathways for CHF and COPD. Locally, as Andrew mentioned, a bigger program with the Ontario Structured Psychotherapy Program. And we're the single point of entry now for Access Primary Care Mississauga, which is a single point of entry for unattached patients in the region. It started a number of years ago and has evolved. Both the major emergency rooms, Credit Valley and Trillium, and the Urgent Care Center, as part of their intake, identify and attach patients who don't identify a primary care practitioner and directly ask for consent to send them directly to this program as part of their flow and pathway as well. So we're not going to touch about the community stuff, but just suffice to say, we do a lot of other community engagement from a primary care lens perspective, as well as the interprofessional care team model. Next slide, please. So going to the physician affiliation. Sorry, yeah. So there we go. So we look at this as an affiliation model. It's a shared care model. It's a social contract, we call it. It's not a binding legal contract, but it really focuses on creating a shared responsibility and fully outlining kind of roles and responsibilities from both sides, from what we expect from our physicians and what we as CarePoint offer the community provider as well. From a physician perspective, it's really about connecting patients that are appropriate to the services or need, which doesn't seem to be the biggest problem because we're all looking for more help as family physicians. But really the biggest part is the physician is still considered the MRP for the patient. So in our discussions, I always talk about we're an extension of your office. We're just not located in the same building. So you're still the MRP for the patient that you want to connect, from a fee-for-service perspective or a walk-in clinic. We have walk-in clinics who are affiliated with us. They are still agreed to be the MRP for that patient's journey through the system and for their care. And we use digital tools. So we use Ocean as our integrating tool. As stated, like Rob said, it'd be nice to be on one EMR. That would be wonderful, but the reality is that's not realistic. So Ocean is our singular kind of entry point that all our physicians use to connect patients to us. And on the other side, we're looking at providing access to all our clinical programs as was listed. We write a written report and we send it through HRM to all our physicians. Reports are, trying to make things an easier kind of how to make your life easier concept is kind of the approach we have. Like our reports, at the top of every report, it says MRP most responsible for, CarePoint Health Clinician most responsible for, patient family most responsible on page 1. So if there's an action item for a physician to identify, it's right on page 1. It's not on page 11 like some of the epic reports from the hospitals come through and you're trying to scroll through. Just trying to kind of simplify kind of the need and work from that. And we provide other practice supports, and I'm going to talk about some of our physician supports and practice facilitation in terms of removing some of those barriers to accessing team-based care and also supporting other digital tools and access and helping back office practice facilitation as well. Next slide, please. So, this is a simplified kind of slide of just about how do we affiliate. Our physician engagement team goes out and reaches out to physicians in practice, particularly in those high needs or identified postal codes. We also look at those who are solo practitioners in the community, as mentioned specifically, who would benefit from support. I meet with every single physician for a 30-minute meeting with everybody who would like to affiliate with us to, on the previous slide, outline roles and responsibilities and expectations very clearly, and really define what we do and what we expect. So there's no mistaking that from a verbal peer-to-peer conversation, but then also through our affiliation agreement after that. We talk about, this concept of, there's 4 different areas I always describe to our physicians that we're looking to help with as CarePoint. Hopkins has this kind of model that 5% of patients are the heavy hospital user. 50% of patients are kind of this, heavy primary care user, complexity, multi-morbidity, kind of a chaotic kind of patient, social determinants of health issues. 40% are kind of maybe complex, but maybe not chaotic, a new heart attack, new MI, a diabetic patient who needs supports and who needs active, but maybe not longitudinal supports. And 40% are kind of episodic, walking well, preventative care, well baby, prenatal services, and everybody's demographics and type of practice changes. And we're trying to help that first 15% of patients in that team-based care model, definitely that next 40% in terms of, providing those supports is from a diabetic primary care lens, from a diabetic support, and from a primary care engagement, self-management support. And then being able to help some of those episodics as well. So, we really openly, transparently said, I can't help every single one of your patients, but the goal is to help those that most at need as well. And that allows us to connect with more physicians in our community at the same time. So we meet with all those physicians. If they're in agreement, our engagement team then sends an affiliation agreement to them. As they sign on, we provide those practice facilitation supports to that physician to onboard. It's not left to them to do on their own. And then that team is then their go-to communication person or point person for any needs going forward, any questions or any other community supports. And again, we talk like we're an extension of their practice, and that's how we try to approach our dealings with physicians directly. Next slide, please. So affiliation, top reasons. Just wanting more support, not feeling isolated, better access to services. When we first started this, as Andrew mentioned in 2017, I went in person to about over 60 physician offices in person just to go meet them where they're at. For almost all of them, I was the first physician to ever walk through their door to say, how can we help you? How can we get in? And I think relationship building is kind of an undersold component of this. It was mentioned earlier as well, but the degree of creating trust in relationships, because most of the hesitations were, what's the catch? Are you going to still be around? Not understanding what team-based care really is, feeling like they're going to lose their autonomy for decision-making. It's going to add more work to my day, or it's just another pilot project, and it's not going to be around. So that was a lot of the early components. I think we had to show value and worth. And as that's gone on and as we've expanded and shown that benefit, word of mouth in the community always goes a long way as well from there. Next slide, please. So in terms of a quick lessons learned, as I said, that the sustained engagement, it's a relationship. It's a relationship building over time. It has to be done. And I'm going to touch on the physician engagement team in a minute. But it's not just off the side of the desk. We have purposefully and from the beginning made sure that relationship building is a huge part of what we do. So I try to meet with all our physicians at some point. It's getting harder with 130 physicians than when we were at 30 when we first started to try to meet. So I had to be a little tactical. Our engagement team is out there communicating with them regularly, going into offices at least once or twice a year in person to make sure it's that those touch points are there. But that peer-to-peer engagement, I think, was also critical to alleviate any fears, to remove some of those initial barriers of hindrance or why should I do this, and being able to speak to them about in simple language kind of what type of patients would be connecting, how be connecting, and just from that simple conversation. and just keeping, the message real simple. I literally say I'm not here to make your business more profitable, but I can make your life easier, and I can definitely help your patients through their healthcare journey. And that's literally the messaging that I kind of simplify to, and it's authentic, I think, and it's real, and it's truthful. And I think that's sounds simplistic, but it's actually very effective over the last 8, 9 years of doing this with physician engagement. And as I said, I think we had to show that we didn't expect a lot. Communication is our biggest ask. We're not in the same building, so how do we communicate? Allowing us to communicate with you, newsletters, reading our emails, responding to our engagement team. And if they don't do it, then I get involved and escalate in terms of this is the expectation. We've already been through this before. So it's that, that approach to communication is difficult when we're not co-located, but it is doable if we're all working together as a team and we're aware of the expectations from the beginning. And I think the last statement is not everybody's ready to join, and we have early adopters and champions, and we have to help those move along. And it has been sometimes where we're in an office where 2 of the 5 join, and then after a year, there are other 3 are putting their hand up and saying, we want to join too. We didn't realize what it was, and we want to be a part of this now. So it's allowing that flexibility, so that we add others to the office as we go, and not just waiting for the whole office for those who want to start as well. Next slide, please. So a big part of this engagement is through our physician engagement team, and our dedicated engagement specialists are a key component from helping us and myself kind of reach out to physicians directly. So there is a difference between peer-to-peer, but there is a huge component of relationship and trust. So they are point people for any questions you have. As a family physician, we talk about if I don't know something in the community from a primary care lens, we are that resource, and we expect to be that resource to help them or find answers to questions without them having to scramble for it. It's a direct two-way relationship, one-on-one supports. We will go on site and put Ocean onto their computer if they don't have it. We will do a demo for the team and their staff and facilitate that. We don't say, you figure out Ocean, then let us know when you got it. Like, we will take that burden off. It's not meant to add work or time to their schedule and to the physician schedule, and we'll work with your admin team. And a lot of our team has relationships with the physicians primarily, but especially their admin team or their support staff as well, because it's just as important for them to work together. We do a lot of continuing medical education events, create a community of practice. We developed a big internal social determinants of health guide, but then we share that resource to our affiliated physicians as well, in terms of all the community services in our area. Again, trying to be that guide so they're not having to look it up on their own. We talk about not declining any services. As I said, I can't see everything. If it's something we can't see, our mantra is to provide that information back to the physician, so you're not starting from zero again, because we're an extension of your team. So we can't see this person for pelvic physio, but here are the 3 clinics closest to you that will see that, so you're not having to look it up on yourself again. So just, again, trying to be that full team approach. There's a small physician advisory council of local affiliated physicians who help meet quarterly, just to get identification. Different EMRs have different problems, different practices have different problems. So it's not just coming from myself as a singular clinical director, but we're getting input from the other physicians in the group as well. Next slide, please. The feedback has been, I think, tremendous. The biggest component is sharing the load and sharing the burden. I'm not going to read the quotes directly, but it's that shared feeling of, I'm not doing this alone anymore. A lot of physicians just feeling that, it was only me, who I don't know who to turn to. I'm just looking on Google for stuff. There's not that interpersonal relationship where they can talk to somebody. At the end of the day, I was feeling alone before, is the stuff I've heard. You saved my practice. I was thinking of, should I keep doing this or not? So I think there's a lot of this feeling in the physician community of just the complexity, especially of patients these days. And adding those team-based resources has made a huge benefit for a lot of our physicians. I have one patient who I inherited from a patient who I already knew, but their physician moved out of the community. And when I got this patient, they were elderly. They haven't really been seeing anybody for 2 years. They were on addictive sleep medication for 30 years. They had COPD. Their diabetes hasn't been controlled. And it's, I'm not taking on patient per se, but it's a very complex patient. And that burden of that initial feeling of, should I even take this patient on, was always on the top of mind. I can't fit anybody else. But knowing you have a team support, it was able to get that patient. They were on temazepam, which is a addictive medication for 30 years. We've got them off that after a 6-month journey with the pharmacist, clinical pharmacist who helped support that with extra touch points, and myself. Our COPD team, integrated care pathway, took over that patient and helped connect them and get their testing up to date and provide them an action plan. And the team helped with their inhaler techniques, and their diabetes got controlled. It's just that feeling of overburdened as an individual family practitioner with that patient who's just bringing on doesn't feel so heavy when the team is there. And it's just a testament to kind of the model of team-based care, even though we're separate, but we're all together. I think we've proven that we can do this as a group and as a team, and it doesn't have to be in the same location. It makes things more difficult, sure, but there's ways to mitigate that and work together to achieve that as well. And I think that's the last of my slides. Andrew, I'll pass it back to you.
Thanks. So I'll just touch on some of the points on our maturity journey. There are challenges. I think there's challenges with any model, but managing expectations, I think, is often a challenge for us. I think, especially when you have primary care physicians who really have lots of needs and wants, and even within our own team, and we have been prioritizing, access, trying to get as much access to team-based care within our community. There's still about 550 primary care providers in Mississauga that still lack connection to team-based care. So, over time, we hope to get better at doing some of the things that we're doing in addition to being able to provide good access. The EMRs, like as we mentioned before, it'd be great to be all in one EMR. Maybe there'll be a magic wand waved soon and that'll happen. But so we have to adopt tools that are the go-betweens, and that's not always easy and perfect, and does add some challenges in terms of our ability to look at data and our ability to communicate. Maybe answer the question in the chat about use of HRM. So we use Ocean to connect the patients back and forth, and that provides some level of interoperability. And we do use HRM. We were the first primary care organization to be an HRM sending facility and use HRM to send our notes back. And I think it would take a data person to fully understand that. But it does leverage the HRM backbone to be able to send notes in the same way a hospital sends notes through HRM to physicians. So it's a bit of a technical answer, but and I don't know the specifics of it, but it does help us do that in a way that provides notes to the EMR of the physician, ideally, and not in the way that you'd hope to be in an ideal future, but it does provide that communication to and from. Our existing infrastructure, we've expanded really, really fast. We opened in 2019 and have grown nonstop, especially through COVID. And we continue to grow with the expansion funding through government, and physical infrastructure is something that we are working on and hoping to have more geographical space locations in a bit more of a neighborhood specific model, but that will lag a little bit, and we have active projects going on right now around that. But that is it does create limitations for some patients who may be in parts of Mississauga that have to drive a little bit further than we'd ideally like. But that's, I think, a reflection of where we are now and not necessarily where we're going. And every team member is different, and no one size fits all. We can't be everyone to everyone, just everything to everybody, and we do have to work with, be realistic about what we can provide and what we can do, and help manage those expectations. All of our physicians are not the same, and they are all in different places. And we are trying to meet them where they're at, and hopefully over time they all sort of start to move in that direction of where we want to be as close of to be a sort of close team. Team works hard, as Sandeep said. It takes a lot of effort, a relentless focus. And being decentralized in a hub and spoke model is even harder because you don't necessarily get that sort of natural run into the hallway conversations that, maybe if you're in the same space, you take it for granted a little bit. We have HHR problems like everybody else. I won't get into that. Everybody knows HHR is a challenge. Where we want to go next. So, we do want to have a more localized neighborhood network model, where we can have a physical presence in each neighborhood, and be able to connect with the primary care providers in a much more localized way. And that'll hopefully allow us to build that a bit more of that neighborhood team approach, to help not only the patients, but those providers feel like they're closer to where the care is being provided. We're looking at how to enhance our practice supports over time. So how do we actually take some of the resources that we have and maybe strategically deploy them, whether that's in certain offices that have the space or of the size where we can take some of those resources and maybe run various clinics, like if running cancer screening clinics at an office for a particular practice, but also looking at things like panel management supports. Can we use resources to get into their EMR and help them mine their data and help them understand who's not getting access to service and be able to help support those connections to our team, which can be a bit overwhelming for a lot of physicians who don't have that type of practice supports or the administrative support within their office to be able to do some of that work. We are looking at expanding our sort of leadership centralized infrastructure role in Mississauga, and that includes working with our family health team partners and CHC partners. An example of how we've done that is the unattached patient program for Mississauga, and we're connected into partners both to receive patients, but also to be able to connect those patients to those where the capacity exists, but also take on more of a leadership role in terms of data and planning and things like that, engagement in the community. And then, look at better tools. I think better tools is something we're all looking at, but how do you, look at EMRs and, helping physicians get on some of the latest tools that are being sort of adopted within our region around scope and AI tools and things like that. So that's all things that are on our work plan, and it's going to take time and resourcing and trust and relationship building to get there over time. But that is where we're heading. We're almost done, and then I'll take questions after. Maybe move to the next slide. So maybe to put a pin in it, is this for you? I think every region has its own challenges, and I think this is a model. I don't like the word model sometimes because I think that whether you're a family health team or a CHC, I think you're really just trying to work as a team, and figure out how to get everyone to communicate and work around the patient needs and support your community. I think some of these models are more administrative rather than barriers to being able to do things a certain way. But I do think especially in a highly urbanized area like Mississauga, where you have a lot of different providers that are soloed, that they're not connected in, that they're disorganized, this is a way, and it's one way that I think you can look at extending access to a team. But it does take a lot of work and energy and a real focus on relationship building. So I think it can be. I think it does offer promise, and I think it is also scalable. And I think that's a big piece of it. It's probably not going to be realistic, nor should it be, to build 35 family health teams in a geography, build buildings, all that sort of thing. Maybe that would be a perfect world, but that's not where we are today. So I do think that this is a model that can be adopted to solve this particular problem. And other regions may have different needs and different model that will work for them. But ultimately, I think we're all trying to sort of work together as a team around the patient. And this is, I think, a good solution for those that have this particular need. I think that's it. Questions?
Yeah, that was fantastic. Thank you both. Don had a question that I think you answered at the beginning, Andrew, about why a CHC versus an FHT, but I didn't want to answer it online because I wasn't quite sure. So,
So I'll say we're a CHC because, for the simple reason is that it was the contract that was available to us from our funder at the time, and for no other reason than that. The other piece around family health teams, and at least at the time, and I think it's been a bit more flexible now is that, our goal was to make sure that everyone can have access to team regardless of your funding model. And the family health team is very specific to FO models and being able to connect. So a CHC is a bit more flexible. We can hire doctors. We probably will for programmatic reasons in the future. But it was really a contractual. We're not a CHC and we're not a family health team technically, and we don't operate as one. We try to sort of take pieces of both. And so I think family health teams will see some of what we do in them, and same with CHCs. So maybe that's the simplest answer.
Great, thank you. Nicole, I know you had your hand up at one point. Do you still want to ask a question?
Yeah, a question and just a comment. First of all, I mean, I love this model. I want this model. I am envious of how this model has really met the need that a lot of independent practices in urban areas are suffering from, in a way that makes sense to the independent practices without them having to sacrifice their independence and still be able to practice in a way that they want to within their own remuneration setup. And I think that, and the other thing, like you said, CHC, FHT, whatever, what's beautiful about it is that you have that physician leadership at, alongside the administrative leadership at the helm. And this is, I think, can be like held up as an example of how much success you can achieve when this is done. And this is something that I think has been a challenge over the years of when we're trying to sort of expand these things, is having that physician model. And you've heard Sandeep, hi Sandeep, talk about the way he meets with every physician. He is funded to do this. So he meets with every physician. He manages that physician relationship, and having that physician to physician support alongside all of the administration support, I think, is a key thing. And the question that I have is, what is the relationship with, organizations like CarePoint with their primary care network and the OHTs? And, is there a way to help to, because I know, as a PCN lead in West Toronto, we are still always bumping up against this sort of lack of understanding between the realities of family practice, independent practice, and the and being able to access care. And I think that having that physician leadership is so important. So what would you say to primary care networks and OHTs? How can we scale this? How can we, what advice would you give us in terms of getting started on this and getting this set up and replicating it in other similar jurisdictions?
I'll start, Sandeep, and then kick it over to you for the hard stuff. I think one of the challenges I have with primary care networks as defined is that it seems to be excluding the team in it in some places. And we talk about sort of PCNs and OHTs, and then it's like asking the teams to then go work with the PCNs on these things like it's a separate entity. And maybe in some places, the province, it does make sense to operate that. In Mississauga, I actually see the team as the anchor of the PCN. And if you look at sort of CarePoint, our model and our ability to sort of go out and build hubs and connect into providers, to me, that becomes a local primary care network of providers that can together, inclusive of the other allied health professionals, the administration, the backbone of the team, to be able to work with those physicians on planning and community of practice and, decision making and things like that. And then, for larger communities like Mississauga, those PCNs you can start to build sort of structures that feed up into a bit more of a overall governance structure. And maybe that's the chair of the local PCNs then form a PCN committee that then works with your OHT. So, I do think that sometimes it's this, we're still separate in some of the planning with OHTs, like it's kind of, but rather than being the anchor for a PCN, because I do think that physicians needed, like a team provides a physician an identity and access and a place to actually feel like they're connecting in to something real rather than this sort of virtual idea.
I want to say I 100% agree with you that this, to me, sounds like a much more effective primary care network that pulls in with a real value add and then can help, sort of advocating for the issues and speaking up. It sounds like a natural primary care network, much more so than the ones that go along beside OHTs and that are, sort of we're struggling in terms of what we're really here for. So go ahead, Cindy.
I think, Nicole, I think that's the answer. I think the first question is, what is your definition of a PCN? Because then that changes your discussion of what that connection and that relationship is. I think there is a huge component of physician advocacy that's needed to speak to the challenges at the practice level, but that's not always a PCN. That is a component of care. I think that, to what you just said, that within our CarePoint network, those physicians can directly talk to us about their challenges and how do we adapt and how do we can add different services and how do we reach them because of their individual needs or group needs or collective needs. So that functions as a de facto PCN with what we're talking about as CarePoint is its own PCN-like structure, which is what you mentioned. So I think that's where the definition of what do we mean as a PCN really comes into the focus. I think that's the difficulty of not losing the physician voice, to your point. And I've been lucky here in this role with the board support and Andrew in his role as executive director of being, a part of the strategic direction and leadership table, even though I'm not a full-time employee per se, but valued as such within the group. And I think that's been, immensely rewarding for me personally, but also feels like we can make that difference and we can pivot to do things and make lives easier from that perspective as well. And I think that's been a huge proponent of that. And then, like I said, the engagement specialist, in my opinion, that relationship building is highly undervalued in terms of how long it takes to do that, how hard it is to do that, how much effort it takes to do that, and how vital it is to actually moving this along. It's not just let's go connect with docs. It's not that simple, in my opinion, and it's very undervalued in general. It's a tick box a lot of times rather than the amount of work that gets put in.
A fine line between a referral center and a team. And it's really the communication and the trust and the relationship that defines the difference, really.
We don't use the word referral. Like I actually say, you're making a connection to CarePoint. You're not making a referral. And words matter. And referral usually means you send them somewhere and some arbitrary time later they come back to you.
You stole that from me, Sandeep, because I've been saying that for like years.
Well,
I'm going to have to interrupt.
It's the right answer regardless.
Sorry, I'm going to have to interrupt, folks. In the last minute, if either Andrew or Sandeep could answer Rachel's question in the chat about funding for the engagement specialist, that would be terrific. This has been really helpful. I think there's going to be a lot more questions. For those of you on the line, if you have more questions, we can send them to Leslie or myself, and we'll make sure that either Andrew or Sandeep get the questions to answer for you. And Rob, I saw that you had your hand up. Did you want to make a comment? You've got about 30 seconds.
To thank both of you for speaking today. I mean, you really have demonstrated around how you build teams for independent physicians in the community and a recipe to do that. It's not, as you say, a referral center. It is really developing those teams so that they actually are functional and can assist for getting the work done for the populations they serve. So just congratulations on this. And there's a million questions I could ask. We don't have enough time, but we're going to invite you back at different times to share more of how you've been doing this.
Wonderful. And just to let everyone know, there will not be an April peer sharing and learning session. We're going to be using that time for planning for the rest of our year next year. So thank you everyone for attending. Again, send your questions to us if you have questions I know I have one for both Andrew and Sandeep, which I'll be sending to them. So this has been terrific and really appreciate you two taking the time to share this program with us. So everyone have a good rest of their day and goodbye.